So last but not least, I'm pleased to introduce Catherine Oldenburg. Catherine is from UCSF. Is an infectious disease epidemiologist in UCSF. She has a master and doctoral degree in science. Her work focuses in antibiotic distribution strategies to prevent infectious morbidity and mortality and epidemiology of antimicrobial resistance among children in sub-Saharan Africa. Very sexy topic now, this of AMR. Very attractive by the whole international community. They say we're losing antibiotics, we need to develop more, and industry is here. So, Catherine, tell us about mass administration of antibiotics. Thank you.
Thanks so much, Marcos, and thanks to the organizers for inviting me. I'm going to talk about the opposite of antimicrobial stewardship. I will talk a little bit as well about, I'm going to start with that kind of taking a step back about how we got to talking about mass administration of antibiotics for child mortality. Why on earth are we even considering this as a potential intervention? By talking about platforms for neglected tropical disease and mass drug administrations for neglected tropical diseases. I work at an organized research unit within UCSF called the Proctor Foundation, which was originally founded for the elimination of blinding trachoma in the American Southwest. That was achieved in the 1950s, and so since then we've moved on to talking about trachoma elimination from the rest of the world. And that is basically a combination of approaches, but azithromycin, mass distribution with azithromycin is a cornerstone. So when people ask me why on earth someone who works in pediatric infectious disease and child mortality has a primary academic appointment in the Department of Ophthalmology, that's why. And I will show you one photo of trachoma, but I promise some of my talks are littered with photos of the eye. It's just one. So. So mass drug administration for infectious disease and for neglected tropical diseases in particular is a particular platform with the goal to administer preventive chemotherapy to entire at-risk populations. And this is really a strategy that's used for infectious disease where there's transmission and an entire population is at risk. So we're not talking about individuals here, we're really talking about populations and communities. These are typically delivered as a campaign style once or twice a year. Usually we talk about annual or biannual treatment for logistic reasons. These are big, complicated supply chain and sometimes cold chain heavy undertakings, and really much more than twice a year is infeasible for programs. These can be delivered by a door-to-door type campaign where you go to every single household in a community, or you can have a central distribution point where people come, there's a mobilizer, there's people go around with loudspeakers and people come to a central distribution point. These types of interventions really require a safe, effective, and low-cost drug. For example, if you're talking about an infection that's predominantly in children, mass administration with cotrimoxazole or doxycycline really wouldn't be appropriate because the safety profile is not really there. There are too many risks, and you can't really undertake treating thousands and thousands of people when there's a risk of an adverse event like that. Some examples of mass drug administration include malaria, seasonal malaria chemoprevention in areas that have highly seasonal malaria epidemics, onchocerciasis with ivermectin, soil-transmitted helminths, lymphatic filariasis, and my favorite NTD, trachoma. So this is the only gross eye photo. So this is essentially the natural history of trachoma. On the left, trachoma is an infection caused by the chlamydia bacteria. It's a different strain than the urogenital strain, but it's chlamydia trachomatis. On the left, you can see sort of the characteristic pattern of what happens to a child who has an infection of their conjunctiva with chlamydia with an inflammatory response. Over several years, many years of repeated chlamydial infections, most of which happen before age 10, this inflammation turns into scarring, and eventually you'll see an inturning of the eyelash. The eyelash will touch the cornea. Every time the patient blinks, the eyelash is rubbing on the cornea. It's miserable. It's very, very painful. And it eventually results in infection of the cornea and a corneal opacity, which you can see on the lower right-hand side. There's not much we can do about this once it gets to this point. There are corneal transplant options, but they're really not available to most of the patients who are suffering the kind of the end-stage trachoma that we see here. Trachoma is still the largest, the most common infectious cause of blindness in the world, so it's still really quite a major problem. It is disappearing globally, and the original goal was elimination by the year 2020. That's not going to happen, but we're making a lot of progress. The curve that I have here is some data from a cluster randomized trial of mass azithromycin for trachoma control that shows 4 annual treatments of mass administration to the entire population. We treat children who are 6 months of age and older in trachoma programs. And those who are younger than 6 months get topical tetracycline. And you can see really that the prevalence of ocular chlamydia, this is PCR positive chlamydia infection, decreases from about 40% at baseline down to hangs out around 5% sort of towards the end. This was in a community in Ethiopia with hyperendemic trachoma, as evidenced by the 40% at baseline. So, as many of you know, azithromycin is a broad-spectrum antibiotic that has a lot of activity against other bacteria. And so, early on in some of the azithromycin trials for trachoma, there were questions about what other kind of positive, beneficial, other effects might we be having, sort of spillover effects, might we be seeing on the burden of infection. Like I said, the chlamydia infection really happens primarily in children, and so this was really focused specifically on infectious burden in children. So studies were done looking at diarrhea, malaria, and respiratory infections, and generally saw positive benefits. The children who had received azithromycin for trachoma control also had reduced burdens of diarrhea, malaria, and respiratory infections. And these are some of the most common causes of postneonatal mortality. These are the most common causes of postneonatal mortality in children in areas where trachoma is endemic. And kind of the culmination of this was a study by Travis Porco and colleagues from my department, which was published about 10 years ago now, showing a 50% reduction in mortality in Ethiopian children who lived in communities that had received azithromycin for trachoma compared to those who were in a delayed treatment arm, where they delayed treatment for 1 year. And this is really a remarkable and sort of unbelievable reduction in mortality that a dose of azithromycin, we're talking single dose administration, could have that kind of profound effect. And so I think my group was probably just as skeptical as the rest of the world. And in collaboration with a number of partners all over the world, we designed what is affectionately known as the Mortar Study. It has a name in French that I'm not even going to try to pronounce. But the Mortar Study was a cluster randomized trial in over 1,500 communities in 3 countries in sub-Saharan Africa in rural districts with no trachoma, so specifically designed to be in areas of the world that don't have trachoma, or areas of these countries that don't have trachoma, in Malawi, Niger, and Tanzania. The study randomized communities to receive biannual azithromycin or biannual matching placebo. And we treated children aged 1 month to 59 months. So we're really looking just at the subset of the population that's under 5 years of age that has the highest mortality. Communities were followed for 24 months. And we did a biannual census to ascertain mortality. The deaths per 1,000 person years in the control arm really varied quite a lot. I want to point out that this is expressed as per 1,000 person years, not per 1,000 live births. Oftentimes you'll see per 1,000 live births. So you would approximately multiply by 5 if you're more used to thinking about mortality in terms of 1,000 live births. But by far the largest mortality rates were in Niger, which was not unexpected. This is a primary outcome from the Mortar Study. This was published last year in the New England Journal. And overall, this is a relative reduction in mortality. So we're talking the relative scale here. There was a 13.5% reduction in mortality in biannual azithromycin compared to placebo communities. And when disaggregated by country, this effect really was being driven by Niger. There was no evidence of a difference in Malawi and Tanzania specifically, although I'll point out that we weren't powered specifically for country-level comparisons. But it makes sense because Niger, like I showed you before, has the largest burden of child mortality in this study by quite a bit. There's a lot of numbers in this table, but I just wanted to make a quick point. This is now looking at the absolute scale, so the number of deaths averted. And again, this is just in Niger. So we looked at the age range, 1 to 5 months, 1 to 11 months, and 1 to 59 months. It's really tempting to think, okay, so we want to limit antibiotic distributions. Can we do it by targeting specific groups? And really the point of this slide is that although we know, as you can see in the data here, that the risk of mortality is quite a bit higher in those younger children, the absolute number of deaths averted is quite a bit less because of the relative sizes of the population. So in terms of maximizing the number of people that benefit, really it is we're talking about the entire population, or treating all of the under 5 children. I promised I would talk about antimicrobial resistance, and so this is just a slide, kind of the unintended adverse events, the bad adverse events instead of the good adverse events. This was a systematic review done by Kieran O'Brien, a PhD student in my group, she looked at all of the evidence of antimicrobial resistance following mass azithromycin for trachoma control. This is specifically looking at macrolide resistance in Streptococcus pneumoniae. By far, most of the evidence has been done with this bug. So this is resistance in isolates just from normal carriage in healthy children in population-based samples. And in general, what we see is an increase in resistance immediately following mass drug administrations or mass azithromycin distributions. And we have seen some evidence that it wanes over time. So once the antibiotic selection pressure is removed, we do tend to see a reduction. What this will look like in terms of antibiotic resistance following targeted just to children, we don't really know, but this is what we know from trachoma studies. I just wanted to make a quick point based on yesterday's discussions about the microbiome. We also do see changes in the composition and the diversity of the microbiome in the short term. We're working on studies now looking at longer term changes following azithromycin treatment, but we do see a reduction in bacterial diversity with azithromycin. So where can this be scaled? So Jean mentioned that child mortality is changing over time. This is a figure from the Lancet a couple of years ago, looking at child mortality rates in sub-Saharan Africa from 2000 through 2015. And you can see kind of the areas of dark red are really condensing into the area in the Sahel. And really where the conversation is about where we would consider azithromycin for child mortality is in that Sahel region, where we really still see child mortality rates that are over 100 per 1,000 live births. So Burkina Faso, Mali, Niger, and that sort of area. So it's very limited in terms of scope and in terms of indication for where this would be considered. And then finally, just to wrap up, in terms of global scale up for mass azithromycin for child mortality, there's discussion about utilization of existing mass drug administration platforms for neglected tropical disease. Can we integrate it into trachoma programs or onchocerciasis programs or other programs? And really there it has to do with where do the epidemics overlap, or integration into existing health systems such as vaccination, where we're already seeing children. And of course, any scale up would have to consider monitoring for AMR. Thank you.
Thank you, Catherine, for showing us compelling evidence of the benefits of mass administration in neglected tropical diseases. Impressive. In the Americas, there is only one focus on onchocerciasis, which is the Yanomami indigenous population in the border between Brazil and Venezuela. In the Americas, is about to eliminate onchocerciasis, and mass administration has proven been very effective.